لو سمحتوا بتتفضلوا ترتاحوا، هنبتدي الجلسة لو سمحتوا. Dear participant, can you please take your seats because we're going to start right now, please?
Yeah.
So we have the two panelists.
Yes. Okay. إذا صار أي تغيير. Good afternoon. Welcome everyone joining us in person and online to the special session on addressing child food poverty in early childhood in the Arab world by mobilizing the food, health, wash, water sanitation and hygiene, and social protection systems. My name is Hisham Jid'oun, and I'll be moderating the session, which aims at sounding the alarm on the crisis of child food poverty, which, by the way, is the state where young children are not fed the bare minimum number of food groups they need in early childhood. More specifically, the session aims at raising awareness on child food poverty and underlying drivers in the Arab world, also launching and mobilizing interest in implementing the regional action framework for improving young children's access to, or young children's, to be more specific, okay. So the regional action framework for improving young children diets at the regional and country level, and also sharing some exciting examples from the regional and country level of actions to address child food poverty. In order to do so, the session will include opening remarks from the regional directors of the 4 UN agencies, given that this is a joint effort. We will have also our keynote speaker in addition to a panel discussion. And if we have remaining time, we'll open the floor for Q&A. Without further ado, please join me in welcoming Ms. Etty Higgins, delivering the opening remarks on behalf of Ms. Adel Khudr, UNICEF Regional Director for MENA. Ms. Higgins is UNICEF Deputy Representative, assuming her role since 2021. Before her current assignment, she served as Deputy Representative with UNICEF Jordan from 2016 to 2020, as also the Deputy Representative with UNICEF South Sudan from 2014 to 2016, as the Deputy Representative in Syria from 2012 to 2014, and previously she was Chief of Field Office in Hargeisa, Somalia from 2009 to 2012, Chief of Field Office in Abeshe, Chad from 2008 to 2009, and also the Chief of Field Office in Bossangoa, Northwest Central African Republic. The role is yours.
Thank you very much. Esteemed colleagues, keynote speaker and panelists, fellow UN colleagues and friends, it's a pleasure to address you today on behalf of UNICEF's Regional Director, Ms. Adel Khudr, as we discuss child food poverty in the Arab region and the actions that we need to take to address this concern. The triple burden of undernutrition, micronutrient deficiencies, and overweight and obesity has been ravaging the growth and development of our children across Arab countries, affecting millions of children. Children and families' poor access to nutritious food is one of the main drivers of this deepening malnutrition crisis in the region. Children cannot live on staple grains alone. They need to eat a diverse range of nutritious foods, including fruits, vegetables, fish, eggs, and dairy products to fuel their growing brains and bodies. Yet today, at least 27 million children under the age of 5 across the Middle East and North Africa region experience food poverty. These children are not fed the minimum diverse diet they need to grow, to develop, and learn. 3 out of the 12 countries in the Arab region, Sudan, Yemen, and Egypt, are contributing to 2/3 of the number of children living in food poverty in the MENA region. Over 1 in 4 children under 5 in MENA live in and suffer from severe food poverty. This means that 10 million children are being fed extremely poor diets that include at most 2 food groups, often cereal only, and perhaps some milk. Children living in extreme food poverty are extremely vulnerable to severe stunting and wasting, the most life-threatening forms of undernutrition in early childhood, which can increase children's risk of death by up to 12 times and undermine their ability to reach their full potential. Fueled by conflict, climate change, and the enduring secondary impacts of the COVID-19 pandemic, a global food and nutrition crisis is pushing already vulnerable children into unprecedented levels of food poverty and nutrition vulnerability. The crisis of children living in food poverty and what it means to children, families, and nations calls for a new vision and response. A response that prioritizes the needs of young children under 2 years, the window of opportunity. And this is critical where rapid and irreversible changes in brain development and growth happen. Progress in this area of work has been slow over the last decades. In order to help member states fast-tracking the progress on improving children's diets to address child food poverty, the UN agencies at the regional level have developed a regional action framework for improving young children's diets to address all forms of malnutrition. This framework will be presented today in this session. To address child food poverty in Arab countries, the governments must take the lead in upholding every child's right to food and nutrition. Together with national civil society, development partners, and the private sector, they must mobilize the policies, the resources, and actors of 4 systems. That is food, health, water, sanitation and hygiene, and social protection to deliver better diets for young children. To end child food poverty, we have 3 critical actions to take. The first is to shape food systems to be more accountable for making nutritious food available and affordable to families with young children. Secondly, we need to leverage health systems to deliver essential nutrition services to young children and their mothers, prioritizing those most at risk. And lastly, we need to design protection systems, including social protection systems that are responsive to food and nutrition needs of the most vulnerable children and families. Before concluding, allow me to reiterate UNICEF's unwavering commitment to support countries and partners in delivering and implementing this urgent response to address child food poverty in the Arab region. Thank you.
Thank you, Ms. Higgins. Now, please welcome Mr. Serge Nakouzi, delivering the opening remarks on behalf of Mr. Abdel Hakim Al-Wa'er, FAO Assistant Director General and Regional Representative for Near East and North Africa. Mr. Nakouzi is a senior level international civil servant with over 30 years of experience and expertise in strategic management and promoting global international development programs. He presently serves as FAO's Deputy Regional Representative for the Near East and North Africa. Mr. Nakouzi possesses extensive policy and operational experience in international development activities focused on the food security, environmental sustainability, peace and human security nexus at the global, regional, and country levels. The floor is yours.
Thank you very much, and good afternoon to all. Distinguished participants, dear colleagues, it is certainly my great pleasure to be with you this afternoon to deliver the opening remarks on behalf of the FAO and the partners partnering with UNICEF and WFP and WHO in regional efforts to improve nutrition and healthy diets. Food security is unfortunately on the rise in recent years, including in the Arab region. We have been witnessing a consistent increase in number of food insecure people in the last few years. The current situation, marred with polycrises, has worsened the situation and exacerbated the challenges that we're facing. As per our latest regional overview of food security and nutrition in the Arab region, the number of undernourished people reached 54.3 million in 2021, or 12.2% of the population across the region, higher than the world average of 9.8%. Now, this is an increase of 55% compared to 2010. The rate of stunting in children under 5 years of age is at 20.5%. Conflict and protracted crises are also major contributors to hunger, food insecurity, and undernutrition in the Arab region. They trigger wide population displacements, undermine incomes, livelihoods, and resilience capacities of households, and disrupt functioning of health and social protection systems and impact nutrition status of populations. Let me touch upon the agri-food systems being the major focus of FAO. In my view, the current setup of agri-food systems, due to production and market mechanisms, encourages poor quality, energy-dense, and nutrition-poor foods, more affordable and easily accessible to the majority of population compared to nutritious foods, which to a great extent are out of reach for many households. The cost of healthy diets is becoming unaffordable to large segments of the populations across the region. More than half of the population in the Arab states, where we have 162.7 million people, could not afford a healthy diet in 2020. In the case of the Arab LDC population, 88.3% are unable to afford such healthy diet. The cost of a healthy diet in the Arab region has been increasing each year since 2017. In 2020, the cost reached $3.47 per person per day. The aforementioned factors, amongst others, are contributing directly towards child poverty, particularly in the early childhood ages. It is therefore imperative that we raise the awareness and advocacy efforts for enabling policy framework so as to address the child poverty and related issues. And this is why the four partners, FAO, UNICEF, WFP, and WHO, have joined hands throughout the regional framework of action And we will certainly hear more about this collaboration and the impact that is being derived from an integrated and more holistic approach across the UN system. In fact, this is pivotal if we are to redress the situation and address effectively the major challenges and the increasing complexity of the issues that we are facing in this area. I hope that today's session will help us all, that means all of the stakeholders gathered, in designing and adjusting and implementing relevant policies and enabling environments to address the key challenge of child poverty in the Arab region. I wish you all fruitful and constructive deliberations this afternoon, and I am in advance thanking you all for your inputs to ensuring that we together can address these challenges. Thank you.
Thank you, Mr. Nakuzi. We all hope so, indeed. Now for the third opening remarks, please welcome Dr. Christoph Hammelmann, delivering opening remarks on behalf of Mr. Ahmed Al-Manzari, WHO Regional Director for Eastern Mediterranean Region. Dr. Christoph was appointed Chef de Cabinet at the Regional Director's Office of the WHO in April 2021. He was the WHO representative for the Islamic Republic of Iran from April 2018 until March 2021. Prior, he was head of the WHO European Office for Investment for Health and Development in Venice, a center of excellence focusing on determinants of health, health equity, and investment approaches for health and well-being in the context of a people-centered approach to universal health coverage. Dr. Christoph, the floor is yours.
Thank you very much. And thank you also for the rapid promotion I see here on my shield, being the regional director now. But as you are rightly saying, I'm representing Dr. Al-Manzari here. Thank you. Distinguished colleagues, food poverty in early childhood is a major concern in the Arab region. Malnutrition in all its forms is taking a heavy toll on health, well-being, and sustainable development. Most countries face childhood stunting, wasting, and micronutrient deficiencies, alongside growing rates of overweight, obesity, and diet-related non-communicable diseases. On top of these challenges, food insecurity in many countries is undermining diets and adversely affecting the nutritional status of the most vulnerable, particularly children, adolescents, girls, and women. Accelerated action is needed urgently to protect populations. We are working closely with other UN agencies on all levels of our organization to address malnutrition. In May 2020, we issued a joint call for action to protect against the potential impact of COVID-19 on food security and nutrition. In 2021, the region adopted the joint UN Global Action Plan on child wasting. And in February 2022, the strategic framework for zero hunger in the Arab region was adopted. In June 2022, we held a high-level meeting on addressing child food poverty in early childhood. As an example of country-level coordination and impact, we have scaled up efforts in collaboration with the World Food Programme and UNICEF to address the increased health risks following the food insecurity crisis across countries of the Greater Horn of Africa, and specifically in Somalia. This included life-saving outreach services in the hard-to-reach areas such as immunization, outpatient consultations, micronutrient supplementation, treatment of diarrheal diseases, in addition to health promotion and messaging on disease prevention. This work reflects the aim of the UN issue-based coalition for food security, climate change, and the environment in the Arab region to align and build synergies in UN agencies' responses. The coordination and collaboration among UN agencies is further supported through the Regional Health Alliance, which brings together 15 agencies working together to accelerate the implementation of health-related SDGs in our region. By aligning our agencies' work, we can maximize our impact where it really counts, on country level, and achieve our regional vision of health for all by all. We count on the high commitment from governments and donors alike. Together, we need to accelerate our impact on addressing and preventing child food poverty in our region. Thank you.
Thank you, Doctor. Now for our last opening remarks, which we will watch as it's recorded. We'll hear from Ms. Kate Newton delivering the opening remarks on behalf of Ms. Corinne Fleischer, WFP Regional Director for Middle East, Northern Africa and Eastern Europe. Ms. Newton is the Deputy Regional Director for WFP's Regional Bureau in Cairo, covering MENA. She is a British national and started her career with WFP as a field monitor in South Sudan in 1999. She moved on to work as a reports officer in Kenya, then in progressively senior program roles in Eritrea, Afghanistan, Ethiopia, and Darfur. She was outposted on various missions during the 4 years that she served in Rome headquarters, including the Haiti earthquake response. And we'll hear more from her.
We're here today to discuss the systematic linkages between child malnutrition and child poverty. The 4 agencies present have identified actions across multiple systems, food, health, WASH, and social protection systems, which can be taken to improve the diets of young children. This systematic approach is in line with the UN Action Framework for improving young children's diets. Together, we have identified areas of collaboration to prevent all forms of malnutrition intrinsically linked to child poverty. The figures to be presented today show that in the MENA region, 4 out of 10 children under 5 years of age are living in food poverty. 1 in 4 children under 5 lives in and suffers from severe food poverty, meaning they have extremely low dietary diversity and lack essential nutrients to cover their needs for growth. This food poverty puts these children at risk of life-threatening forms of undernutrition, which can increase their risk of death by up to 12 times and undermines their ability to reach their full potential. WFP, like other agencies, is working in partnership with governments to implement large-scale programs. These include food-based malnutrition treatment and prevention programs in Syria and Yemen. It includes cash-based transfers in the form of the National Poverty Targeting Program in Lebanon, where there's also a supplementary emergency social safety net program. And in Egypt, WFP is working with the Egyptian Ministry of Social Solidarity to target pregnant and lactating women and to provide cash transfers to enable greater dietary diversity linked to health checks and nutrition information to encourage behavior change. WFP also works alongside partners to provide education. We are working to ensure that where school meals are provided, that we improve awareness to increase the quality of healthy diets. WFP is also supporting national level data collection through the Fill the Nutrient Gap and Cost of Diet analysis in some countries to help understand local barriers to accessing healthy and nutritious food and to seek solutions to meet such gaps. The increased cost of food since the outbreak of the war in Ukraine and the impact of climate change, economic downturns, and recent global events have created further barriers to accessing a healthy diet for the poorest. We will continue to work in collaboration with our key partners to continue to address child poverty and malnutrition across the region. Thank you so much.
Now we welcome our keynote speaker, Dr. Lara Nasruddin, who's going to be presenting the Child Food Poverty and Regional Action Framework for Improving Young Children's Diet. Dr. Nasruddin is a professor of human nutrition at the American University of Beirut, AUB, where she is heavily involved in research, teaching, and community service. Her main research interests focus on dietary assessment and the investigation of diet-disease relationships, with a focus on the pediatric population. Her scholarly work includes more than 100 scientific publications in internationally renowned journals. She was recently awarded the designated board professorship at AUB and won the Abdul Hamid Shuman Award for Arab Researchers in 2014. She has also worked on numerous occasions as a nutrition consultant for WHO and FAO. Floor is yours, Doctor.
Thank you. I hope everyone can hear me properly. Again, thank you everyone for this opportunity to contribute to a topic that is actually dear to my heart, child food poverty, because I work a lot on dietary practices of children. And again, oops. Does it work?
Yeah, should work.
All right. So what we're gonna do, short presentation, is to basically go over or overview a little bit the burden of malnutrition and child poverty in the region. And again, to present the multi-systems action to improve the diets of young children. And by young children, this action framework really tackles the age from 6 months to 23 months, which is referred to as the complementary feeding period. So why does the diet during this period matter, the period from 6 to 23 months? Because really the studies have shown, data has shown that access to a diverse range of nutritious foods, diversity in the diet, would actually provide children with all the essential nutrients that they need, including macronutrients, including vitamins and minerals. And this will help them to develop not only their full physical potential or their growth from a physical perspective, but also more importantly from the cognitive perspective, and will give them really the best chance for the later health trajectory that they will have as adults. So this period is recognized as a critical opportunity. And we can also say that it is recognized as a window of opportunity where interventions would actually matter for the future of the child. It is an opportunity where we can prevent all forms of malnutrition, whether it is undernutrition, whether it is overnutrition. What is the data that we have on undernutrition markers in countries of the region? The data actually are rather grim for many countries of the region. So we can see that the burden of stunting in under 5 children is actually very high in some countries of the region, especially those that actually are witnessing some kind of conflict or instability. And prevalence rates like almost 45% of children are stunted in Libya, more than 35% in Yemen. These are huge figures, huge prevalence rates. Again, in Sudan, in Syria, the prevalence rate is defined based on the WHO cutoff as very high. Again, the situation in other countries, the ones that are in brown color, well, they are still high. They range between 20 and 30%, such as Egypt and Somalia. And we have lower rates in other countries like the Gulf countries or the Levant countries like Lebanon or Jordan and like I said, Gulf countries. So in some countries, really, the burden is huge. And this is not to be taken lightly. This is not that, okay, the child is going to be shorter than others and that's it. No, the impact is much more significant on the future of these children. It is their cognitive growth, their cognitive development, their educational attainment, and therefore their income and their productivity as adults. So this actually is a grim picture, not only for children, but also for nations in the region. And unfortunately, from studies, we know that these deficits that happen early in life, in growth or in cognitive development, are irreversible. We can't fix them later on. It's a one-way street. When it comes to wasting, again, the prevalence rates are very high, exceeding 15% in many countries of the region that are, in instability, such as Yemen or Sudan, but also very high levels in countries like Saudi Arabia. It's high, it's like between 10 and 15%, where you have like some kind of political stability. But why is it that the prevalence is high? Is again something we need to look into. Data coming from Syria, from Somalia, are also high levels of wasting in these countries. Again, the data are a little bit better for Lebanon, Morocco, Iraq, Egypt, but at a regional level, the burden is really significant. Again, wasting is a significant risk factor for both morbidity and mortality of young children. It is actually the form of undernutrition that is associated with the highest risk of mortality in this age group. We should not forget that overweight and obesity are also forms of malnutrition. You can actually be obese and be malnourished. And actually, we know that stunted children are at risk of becoming obese. You can be obese and have micronutrient deficiencies. And the burden of overweight and obesity has been escalating in countries of the region during the past few decades. And we do have very high levels in countries like Libya, Lebanon, Syria. These are based on the 2021 data, and Egypt and Tunisia, a bit less in Qatar and Algeria. But really, when we look at the average prevalence of overweight and obesity in our part of the world, we do exceed the worldwide average. And what is more worrisome is that based on studies we've conducted, we actually have an accelerating trend. So data are still increasing. The prevalence is still increasing. Why is this a problem? This is not only a child that is chubby and cute with a cheeky, cuteness. This is a risk factor for their health, not only as adults, because I hear a lot that, overweight children are likely to become obese adults. Of course, this is a significant risk factor, but also in children. In very young children, we do see cardiometabolic abnormalities. We do see hypertension. We do see dyslipidemia. We do see insulin resistance. And this actually means that the disease risk from the risk for NCDs is extremely high in these children. So we do have a crisis in all forms of malnutrition in countries of the region. And this malnutrition crisis is driven by what we call a child food poverty. So if we look at all forms of malnutrition that we are seeing in this slide, so stunting, wasting, micronutrient deficiencies, and overweight, the immediate determinants are actually the level of care that they receive. I can't see it on the screen. So the level of care they receive, if they are sick, if they are receiving adequate counseling. So of course, the level of care is a direct determinant. But the other very important determinant is the diet that these children are actually receiving. And poor diets or child food poverty is actually rampant in countries of the region. And as we have heard already, 1 in 4 children in the region have severe food shortage, not the moderate form, the severe, the one that really cripples their growth and development. So this is where we need to work. We need to improve the diets of these children. But how do we improve the diets of these children? We need to understand the determinants, the factors that can have a direct impact on the diet of children. And this is an illustrative adaptation of the new UNICEF conceptual framework adapted to the Arab context that actually visits the 3 determinants, what we call underlying determinants. So basically food, practices, and services. So the child needs to have access to adequate foods, access to adequate practices by the caregiver, and access to adequate nutrition and health services. These 3 underlying determinants interact with each other at multiple levels in shaping the diet of these children. And unfortunately, when we visit the situation in our part of the world, when we talk about access to adequate foods, well, this is problematic in many countries because of food insecurity, because of lack of purchasing power at the level of many households, because of rising food prices and a dichotomy in prices between what's healthy and what's unhealthy. Unfortunately, ultra-processed foods that are rich in, sugar, salt, and saturated fat and trans fat are becoming very cheap, so people can afford them. Whereas healthier forms of diets, the minimally processed foods are like fruits and vegetables, are becoming more expensive. When we visit the practices side, again, what we know from data is that there are poor infant and young child feeding practices. So the caregiver is not always, giving adequate practices. So for example, data show that 1 in 2 children in the region actually receive vegetables or fruits during any specific day. Like 50% do not receive any fruits or vegetables. And these practices by the caregiver depend on so many factors. One of them is the level of knowledge that the caregiver has, their attitude towards certain feeding practices. It could sometimes be the mental health of the caregiver, stress or emotional well-being. It could be, again, things related to gender role and the distribution of food within the household. Access to adequate services is another very important determinant. And here we're talking not only about the scale of coverage, we're also talking about the quality of these services. So they could be available, but delivered, with poor quality, we will still have a problem with that. And here we're talking about not only medical, but also any other essential services related to health, to wash and having wash-related services, to micronutrient supplementation that might be the solution sometimes in certain situations, the scarcity or the unavailability of clean water. And these services have really undergone serious disruption during the COVID-19 pandemic. And all of these have been also further compounded by the conflicts that many countries are harboring, or also the economic crisis in many countries. So these are the main underlying determinants that shape the diet of these children. But also these determinants themselves depend on other factors, bigger factors at the national level or the regional level. They include resources, from the financial aspect and from the human resource. And it also includes social norms and cultural factors. So we could say that, the knowledge or the awareness of mothers to breastfeed or not may depend on what's happening as cultural norms. So the excessive use and marketing, for example, of breast milk substitutes has indirectly shaped the way that young children are being fed. Again, social and cultural norms are, the nutrition transition, the westernization of the diet, the so-called modern diet, the cool diet is also changing the way that children eat. And actually underlying all of these is poor governance. So all of this, sorry, what's happening? Underlying all of these is actually poor governance in relation to nutrition. So from the political, the financial, all of this poor governance will directly shape all of these determinants. So we are talking based on this figure, I don't know if you saw it, that the data show that for the diets, 1 in 4 children, like I said, suffer from severe food poverty. So what is the scientific definition of food poverty? First of all, the UNICEF and the WHO define the quality of the diet based on the minimum dietary diversity score that is calculated for children between 6 months and 23 months. So, and a diverse diet is considered a good quality diet. And children, when the child is not able to meet the minimum dietary diversity, we say that the child is suffering from food poverty. Let's understand this a little bit more. So to meet the minimum dietary diversity for healthy growth, for healthy development, the child needs to consume at least 5 groups out of the 8 food groups that are shown on this slide. So the 8 food groups include breast milk, because as you know, the recommendations are to continue breastfeeding until a minimum of 2 years. So breast milk, in addition to grains and tubers, vitamin A rich fruits and vegetables, flesh foods like meat and poultry and fish, pulses, nuts and seeds, eggs, other fruits and vegetables, and dairy products. So when a child receives 5 out of these 8 groups, we would say that he or she is meeting the minimum dietary diversity. However, when the child meets less, for example, when they're taking 3 to 4 food groups per day, so they're not meeting the 5, but they are meeting the 3 to 4 food groups per day, we label this as an experience of a moderate food poverty. So they're already in food poverty because they're not receiving the minimum dietary diversity, but they have a form of moderate food poverty. When the child meets even less, so he's receiving or she is receiving 2 food groups or less per day, so anything between 0 and 2 food groups per day, we will label this as extreme food poverty. And the value that we have seen in the previous the previous slide has shown that 1 out of 4 children in the Arab region has severe food poverty. So taking 2 or less, 6 minutes? No. All right, so I'll try to be as quick. The prevalence of child food poverty, like we said, is actually 42% of children in the MENA region face a certain form of food poverty, but so this is equivalent to 26 million children in the region. When we look at severe food poverty, it's actually 25%. So 10 million, or 1 out of 4, like we have said, face severe food poverty. The variation between countries, again, there is a significant variation between countries. So this is for the countries that have data, and we can see that countries like Djibouti, 89% of children have food poverty, but the values from Yemen, Lebanon, 77% of children face food poverty, and also from other countries shows a huge burden. When we go to the extreme food poverty, we can see that in many countries, more than 25%, like in Egypt, Yemen, Syria, and Sudan, have extreme food poverty. So they're actually not able to consume more than 2 food groups per day. Again, this can be, like was said, some cereal or some milk that is in no way sufficient to basically meet their needs. So, of course, this crisis of child food poverty needs to be addressed, and there is a need for action to improve the diet of young children. And it is in this context that so why is it so? Like we said, because children under 2 years of age have extraordinary milestones in their physiological and metabolic development. So from the maturation of the nervous system to the increase in height and in body weight, they are actually amazing type of growth that happens in this age group. So they have very high nutrient needs, and at the same time, they have very small stomachs. So we need to feed them smart. We need to basically maximize on the quantity that we are feeding them so that it's going to be rich in nutrients. So in order to basically, there is an urgent need for efforts to improve children's diet. But unfortunately, during for as long as we remember, maybe the strategies and programs that have been implemented have actually been very fragmented. So we have fragmented actions that try to improve the diet of children. And when the interventions are fragmented, they do not have the capacity to reach most children. And of course, they do not have the capacity to comprehensively address all the challenges faced when it comes to children's diet. So this is why, if we want to revisit the conceptual framework I have presented earlier, if you want to improve the diet of children, we need to tackle the determinants, the underlying determinants of these diets, which include adequate foods, adequate practices, and adequate services. And it is in this context that the UN agencies have all come together in order to propose the action framework for improving young children's diet. And really, this framework, what it really aims to do is to facilitate the how to activate the potential of 4 different systems. We heard already a little bit about the systems, but I will go into these systems in a while. So to activate the potential of these 4 systems to deliver the strategic actions and intervention to improve children's diets. And it also aims to facilitate or to give the how-to on how to make these 4 systems more accountable for delivering nutrition results. And of course, all of this should be done not only in mere collaboration or mere coordination. It has to basically underlie the need for a shared vision, really a shared vision between the various stakeholders, joint planning and joint monitoring in order to make an impact. So the multiple systems we're talking about include the food system, the health system, the water and sanitation system, as well as the social protection system. And in fact, if we think about it, each of these systems plays a role in shaping somehow children's diets. And leveraging the potential of each of these systems to modulate the diet will give a much broader range of opportunities to reach children and their caregivers. So you'll have a more holistic approach in dealing with them. So this brings us to the actual action framework. And you can see again, there are the four systems that are really clarified here. But you can see that, okay, I want to develop strategic actions across the system, across these systems. What are the priorities in my country? I wouldn't know. I wouldn't like to take the priorities from other contexts. So this is why what precedes really the identification of the strategic actions across the systems, what precedes this is a thorough situation analysis. An analysis that allows us to understand the context-specific gaps, bottlenecks, and barriers against healthy foods in children, while focusing again on the determinants of the diet. So access to food, access to services, and access to practices. This can be done by mapping the policy environment, looking at studies in food consumption, care practices, caregivers' knowledge, etc. And once we identify these priorities, we can actually see where we can leverage these different systems into improving the diet of children. And once we identify these strategic actions, we need to think that these actions also need to be delivered at multiple levels. So it's a multi-level approach at the policy level to influence, at the institutional level to build capacity, and at the community, household, or individual level to bring awareness and to create more sustainable practices for healthy diets. And of course, underlying all of this is the programming context, the setting in which the programs are to be delivered in a country, which depends on the local situation of food security, of a humanitarian crisis. You know, these will shape your priorities and the way you would deliver. And of course, we should never forget that any intervention needs proper monitoring and evaluation to improve the process. This is a very busy slide and I do not want to go into it. It's just to show you that, again, they are outlined across the four systems based on policy, institutional level, as well as community. An example of the food system intervention. So again, the food system, remember, it includes the food supply chain, the food environment, and the behavior of caregivers. For example, at the level of food environment, it can include taxation, proper promotion, banning of the advertisement of unhealthy foods, the development of food-based dietary guidelines that can be adopted at the institutional level, and at the behavior of caregivers level. For example, we can empower women to have better decision-making when it comes to food purchasing. So when we go to the health system, again, you have the services and you have the behavior of caregivers. So basically at the policy level, you can strengthen certain policies and legislations, whereas at the institutional level for the caregiver, you can train the institutions, enhance capacity to deliver proper counseling. When we go to the WASH system, again, proper diets, proper health care. With poor hygiene and poor water, we wouldn't have done anything. So at the institutional level, you can provide a technical support for governments to have WASH services. And at the level of the caregiver, you can also teach and implement certain awareness and counseling in the institution on proper IYCF and safe food handling. And finally, for the social protection system, the mere job of this system is to basically help the needy, the disadvantaged, the poor families to have access, to be able to afford food, to be able to afford certain essential services. Again, at the level of the behavior, you can do women empowerment. At the level of the policy, you can enhance the nutrition sensitivity of certain ongoing programs. So this framework, this action framework comes as a call to action, and actually it is a call for bolder action and greater accountability to end child food poverty. For this, the government should come together with the partners, the UN agencies, humanitarian partners, the civil society, and the private sector also, in order to mobilize the food, health, and social protection systems to improve the diets of children, and therefore to guarantee every child's right to food and nutrition everywhere. And thank you for your attention.
Thank you.
Thank you, Doctor, for such a comprehensive and much needed framework. And luckily, we have among us today Ms. Karima and Dr. Atif to give us concrete and hands-on experiences and examples from Egypt and Yemen. I'll introduce them first, and then we'll ask them a more specific question. So I'll start with Ms. Karima Al-Hada. She's the Scaling Up Nutrition Secretariat at the Ministry of Planning and International Cooperation in Yemen. She led the development of Yemen's multi-sectoral nutrition action plan and the establishment of Yemen's Scaling Up Nutrition networks. She is actually the convener and lead for the National Food Systems Dialogue in Yemen. And currently, she is supporting the national efforts of enhanced humanitarian development and peace-enabling nexus mechanism towards sustainable food and nutrition interventions in Yemen. Thank you for being with us. And I'll introduce Dr. Atif Al-Shitani from Egypt. Dr. Atif is the advisor to the Minister for Population and Health Issues at the Ministry of Social Solidarity. He has 30 years of experience in the field of population, reproductive health, and social protection, where he contributed to the drafting and implementation of national population and reproductive health policies and strategies, and implementation of many national programs addressing the development, poverty reduction, and health. He served in Egypt's Ministry of Health and Population as the first Undersecretary of the Ministry of Population and as the rapporteur at the National Population Council. He's currently working as a consultant in MOS, developing social protection policies and designing and operating health conditionality systems with respective agencies. So I'm going to start with the first question, Doctor. So in your experience, what are best practices in mobilizing social protection systems for addressing child food poverty?
طبعا هي الدكتورة لارا أثارت الشجون بالعرض الجميل بتاعها يعني. وبصراحة أنا كنت جاي علشان أعرض بعض النقاط الخاصة بالمداخلات جوه مصر، بس اكتشفت إن الموضوع أكبر وأعمق. إنما عشان كده هحاول أكون مختصر أو ببداية منطقية على قد خبرتي في المعلومات، لأن أنا عارف إن كانت في مشكلة في مصر. أنا أتكلم على مصر في المعلومات لفترة طويلة، لغاية ما بدأت مصر من عام 1988 تبدأ المسوح السكانية الصحية على المستوى القومي، ودي كانت نقلة لمصر، لأن احنا كنا شغالين زي ما بيقولوا في الدارج في المصريين، احنا كنا بنشتغل في الضلمة، احنا مش عارفين ايه الحقيقة. احنا في السنة اللي فاتت او من عدة شهور ظهرت نتائج المسح السكاني المصري، ودي يمكن احب اكد عليها، لان في فترة فجوة من 2014 المسح السكاني الصحي اللي اتعمل بدعم من المعونة الامريكية هو بيكلف كتير. النبادي المسح الأخير اتعمل بفلوس مصري 100% وبخبرة مصرية 100%. من 14 ل 2022 ظهور النتائج يؤكد أن الاستدامة هي كلمة إنما مكلفة، هي ليست سهلة. نقل الخبرة والاستعانة بالدعم المحلي أو الفلوس التمويل المحلي علشان أنفذ مسح ضخ هو نجاح لمصر، انما هو لازم يكون في اتجاه على مستوى الوطن العربي كله انه يحاول بقدر الامكان ان هذه المسوح تكون بايدي وطنيه علشان نقدر نستخدمها في المستقبل. النقطه الثانيه طبعا يعني قاعده البيانات، لان انا عندي يعني يمكن في مثال هستخدمه علشان الوقت المتاح ليا 8 دقائق، وده لا يكفي طبعا الحديث على 100 مليون او اكتر من المصريين بمعاناتهم. احنا عندنا في مصر 30% تقريبا من السكان تحت خط الفقر. حتى الفقر نفسه مش متوزع بالعدل في مصر. عندنا مصر على مجرى النيل، المنطقة اللي فوق اسمها الوجه نقول ايه لور ايجيبت او معرفش ايجيبت والوجه القبلي او الجزء الاسفل هو الاشد فقرا، الجزء المنتشر فيه الفقر ومنتشر فيه الجوع والمشاكل كلها اللي الدكتوره لارا اشارت ليها. عشان ندخل في النقطه على طول، انا من الناس اللي كنت بحلم ان الحكومه الحكومه المصريه تتصدى لهذه المشكله، لان المشكله ليست هي في الظاهر فقر وجوع وأمية منتشرة وجهل منتشر، إنما الموضوع أعمق. وهذا ما اتجهت له الحكومة المصرية في الفترة اللي فاتت عندما بدأت في تنفيذ هو أكبر مشروع تنموي في تاريخ مصر، هو سموه حياة كريمة. يعني استهدف 20 محافظة واستهدف البنية الأساسية داخل كل قرية علشان نبدأ نعيد يعني تقديم بناء وحدات صحية، بناء فصول، وبناء وحدات اجتماعية تساعد على تقديم الخدمات بجودة معينة. وهذا المشروع يعني جواه مشروع أكبر اللي هو مشروع تكافل وكرامة، اللي يمكن هنتكلم عنه النهاردة يعني لأن أنا برضو بأشرف إن أنا جزء منه، لأن هو لأول مرة في مصر يبدأوا يعني يدوا منح للفقراء مشروطة. ما حصلتش قبل كده. يعني هي البنك الدولي مشكورا هو جاب الخبرة أو يعني أشار إلينا باستخدام هذا الموضوع اللي تم تنفيذه في أمريكا اللاتينية. فمن سنة 2015 بدأ شرط إن المنح ما تبقاش منح كده للفقراء، إنما لابد أن تكون مشروطة بسلوكيات معينة. هي ليست مشهورة، ليست للتعسف، يعني ليست شروط تعسفية. الشروط كانت وعلى فكرة برضو من المهم ان احنا نقول ان كانت معظم البرامج المدعومة من الجهات الأجنبية لا تصل إلى مرحلة المأسسة، ودي طول عمرها بتعاني من كده. يعني أنا راجل، أنا بتكلم إن أنا اشتغلت مع المعونة الأمريكية من التسعينات. أكبر برنامج كان في أفريقيا كله لتنظيم الأسرة والصحة الإنجابية، كان برنامج قومي يعني وطني وقومي. وهناك يعني نقول إيه، استمر البرنامج لسنين طويلة دون مأسسة، دون أن يدخل أنشطته داخل تبقى لها دور داخل الحكومة. هناك أشياء يعني لحقناها بسرعة، يعني وصلنا لها زي شراء وسائل من الحمل، أصبحت دلوقتي بأموال مصرية. بس عشان كده من المهم إن احنا لما نتكلم على الاستدامة نبقى عارفين إن نقل الأنشطة اللي موجودة اللي الدكتورة لارا استعرضت إن هو إيه اللي المفروض يتعمل. هناك فرق ما بين صالون يتم تداول واستعراض فيه الأفكار والتوصيات، وهناك مطبخ اللي هو كمثال للمطبخ عندما نطلب من الرائدة الاجتماعية أو البنت الصغيرة أن تقوم بزيارات منزلية للأسر الفقيرة لتعليم السيدة كيف ترضع طفلها وكيف تعلمها أن تطبخ بشكل معين. هذا هو التحدي الأكبر. كتابة الاستراتيجية يعني سهلة، مش معضلة، إنما تحويل السلوك للسيدة الفقيرة من إنسانة تعتقد أنها يجب أن تتصرف مثل الأغنياء، أنها ترضع ابنها ألبان صناعية ولا تلجأ إلى اللبن الطبيعي. عشان أغير هذا السلوك محتاج جهد، محتاج إن أنا أخلي هذا الرسول اللي هو هينقل الرسالة ازاي يبدأ يستمر في الاحتكاك بهذه السيدة لفترات طويلة علشان يبدأ يتغلب. انما اللي انا بشوفه ممكن تلاقي دورة 3-4 ايام وخلصت الموضوع، وننتظر المعجزة ونقعد 2-3 عشان ننتظر نتائج المسح يعني. المهم تكافل وكرامة، عندي ارقام مهولة طبعا، لان انا عندي 15 مليون أسرة تستفيد من تكافل وكرامة. 15 مليون أسرة مصرية، يعني لا سوري، حوالي 5 مليون أسرة مصرية بحوالي 15 مليون إنسان مصري، عشان ما حدش يفرق كتير. طبعا هناك تكافل دعم نقدي مشروط، وهناك كرامة دعم نقدي غير مشروط. المعظم اللي بياخده هو دعم نقدي مشروط، والشروط 3 شروط: أن أم بأطفالها تذهب إلى الوحدات الصحية لتلقي خدمات الرعاية الصحية الأولية المجانية التي توفرها الحكومة لجميع الأسر، فده من سن 0 لعمر الطفل 0 إلى 15. وطبعا هناك يعني خدمات كثيرة يعني مجانية من خلال الخدمات الصحية. الوحدات الصحية تبلغ حوالي 5400 وحدة صحية بتقدم خدمات من أول الفحص، سكرينينج أو مسح لاكتشاف الأمراض نقول الوراثية، ومتابعة النمو والتطعيمات. ومصر فيها برنامج تطعيمات أساسية للأطفال، يعني له شهرة لأن هو بيعدي نسبة التطعيمات أكثر من 90%، وتنخفض عن ذلك في محافظات الوجه الإبلي، مشكلة اللي دايما مع الفقر يعني. هناك متابعة النمو، وهناك مشكلة علشان برضو أتابع، معرفش المشكلة دي موجودة في الوطن العربي ولا لا، إن إحنا الولاد في متابعة النمو مهم جدا السنتين الأول علشان أعرف أكتشف أمراض سوء التغذية، إنما ليس هناك متابعة بالشكل النموذجي بعد 2 بتتوقف المتابعة. فأنا معرفش إذا كانت دي مشكلة عامة ولا لا، أو بنصحوا بيه. المهم المشروطية الصحية لغاية 6 سنوات يجب على الطفل الأم وأطفالها التردد على الوحدات الصحية، وفي نفس الوقت يجب على الأم بعد 6 سنوات الالتزام بالذهاب إلى المدرسة. هناك نسبة أمية منتشرة وتسرب من التعليم. نحن نتوقع أن هذا البرنامج يعني يحسن هذه المؤشرات اللي هي مشكلة. ثانيا الشرط الثالث هو زواج الأطفال، ممنوع زواج الأطفال. هناك أماكن في مصر يتزوج فيها الأطفال طبقا لقانون مصري. الطفل هو من يعني تحت 18 سنة، يعني لا يجب أن يتزوج لا الطفل ولا الطفلة حتى 18 سنة. فهذا الشرط هو اللي موجود، وأعتقد أن احنا بنعاني في مشكلة كيف نترصد هذا، نترصد زواج الأطفال. عندنا في تعاون بين وزارة التضامن ووزارة الصحة في ترصد زيارات الأمهات إلى وزارة الصحة وحضور الأولاد في المدارس. يعني هناك برنامج مشترك لترصد هذا الموضوع. هناك برامج أخرى زي برنامج ال1000 يوم، وده من البرنامج المهمة والخطيرة اللي بتتم داخل مصر. هو البرنامج جيد. هناك نصيب لوزارة التضامن بتتعامل مع برنامج الغذاء العالمي وبتحاول بقدر الإمكان إنها توصل للأمهات. أكبر تحدي في مصر بالرغم إن أنا عندي قاعدة بيانات 15 مليون فرد و5 فقراء، إنما لا زال الوصول للفقراء موضوع ليس سهل. علشان كده برضو برنامج ال1000 يوم بيحاول يوصل للحوامل اللي هم بيترددوا على وزارة الصحة علشان نقدر نوصل لهم ونديهم المنح اللي هي موجودة في الوقت الحالي وبيوفرها البرنامج. يعني في برنامج ال1000 يوم عندي في المقابل اليونيسيف، منظمة اليونيسيف بتعمل معانا، أنا بعمل معانا، لأن رغم إن بيدعم وزارة الصحة إنما هو معانا لأن هي الإنسانة هي مستهدفة من وزارة التضامن ومن وزارة الصحة ومن جميع الأجهزة، فكلنا بالتأكيد يعني بنفكر في نفس الهدف. يعني واليونيسيف، منظمة اليونيسيف مشكورة بتدعم وزارة الصحة في فترة ال1000 يوم. طبعا هي فترة من أول حدوث الحمل لغاية 2 بعد الطفل، فترة خطيرة جدا من حياة الطفل. وأعتقد إن هو مطلوب كثير من التكامل ما بين هذه البرامج وكثير من التنسيق، مزيد من التنسيق للوصول للنتائج. الوقت عدى طبعا. أنا عارف. أنا قلت لك أنا قلت لك 100 مليون. يعني انا بحاول افكار بتتطاير وانا بحاول المها. انا مش عارف يعني هي مش دي لحظه، هو في فرصه للرد على اسئله او حاجه ولا هم شويه بتوع يعني. طيب اخر سطر هقوله، انا طبعا نفسي ان انا يعني ان انا اذكر في برنامج تغذيه منزليه. ما هو دي حاجات اصلاح حاجات. انا هنا لا ادعو الى يعني لا ادعي شيء. برنامج التغذيه المدرسيه برنامج، انا من الناس ان انا وانا طفل كنت باخد من المعونه الامريكيه. كان المعونه الامريكيه بتوصل للمدارس بتدي لبن انما انا دلوقتي بشوف الولاد الصغيرين بياخدوا من الفلوس المصري تغذيه مدرسيه، وده شيء جميل لازم اذكره لان دي احد الحلول اللي ممكن تكون مؤثره. الخلاصه هي بعض التوصيات في الاخر. انا بقول تحديات، هي مش كل شيء جميل. الاستدامه، التنسيق على جميع المستويات. أنا عندي 14,000 رائدة أو مجتمعية في القرية، يعني على مستوى القرى وزارة التضامن، ووزارة الصحة عندها 20,000 رائدة، يعني أو العكس، يعني ده عنده 10,000 وده عنده 10,000. ودي وحدات ووحدات. الجهات المانحة التنسيق بينها مشكلة برضه، ودي مشكلة مزمنة من زمان، مش خاصة بالطفل بس، هي مشكلة لازم يكون لها حل. أما في جودة الخدمة، أنا ما شفتش مثلا قياس لجودة الخدمة. الخدمة لازم أنا أقيس الجودة، لازم أراعي الخصوصية. يعني أنا لازم أعرف إن الفقير فعلا بياخد حقه بدون ما يكون الناس كلها عارفة إن هو يعني كلها حاجات أنتوا عارفينها، واضح في توافق غير تكامل الخدمه في الاخر طبعا، ودي حاجه مهمه. انا اشكركم جزيلا.
شكرا.
ورغم اني حاسس بالحرمان من الناس
والله
انما انا مقدر ظروفكم الوقت طبعا، وبعد الاكل وبريك ورا بريك والنوم بيتقل.
لا يعني الشعور بالحرمان مشترك في العالم العربي. Thank you so much, Doctor, for your contribution. I'll move quickly to Dr. Nadia. She's the Associate Professor and Head of Research and the founder of the Center for Resilience and Sustainable Development at the University of Cambridge. Doctor, we're interested in learning more about and hearing more about the case in Yemen, basically based on your research. How do countries find the resources to address childhood malnutrition in a war zone, specifically on making minimum acceptable diet a high priority for relevant sectors? Can we do this in 3 minutes?
that would be a disservice to the children. However, given that we want to use our time efficiently, yes, I think the main message can be done in 30 seconds, which is that regardless, whatever coordination we talk about, regardless how many times we put these big banner numbers out there in front of you to, kick off some imagination, if you cannot find a sustainable business model that serves the governments in some cases, to encourage the private innovation, to kick on, to take the charge of making minimum acceptable diet viable and accessible at the household level, we are just fooling ourselves. The critical point here is that, as the Egyptian representative just mentioned about the survey done by USAID and the government of Egypt not having one of those data points, is a critical issue. The second one he also highlighted with great frustration is that the succession policies from handing over projects from the donor initiatives to the government is also something that has quite a difficult terrain. And someone of his caliber working in such a great depth in the society, still having that level of frustration, speaks the volume that we are looking at the problem from a statistical point of view instead of making it as a practical problem where the money needs to flow sustainably to not only improve children diet, but also to actually connect those who actually provide services. One of the framework that was shared with the mothers and carers who actually knows where to go and get their resources. The third thing that came out from the third thing that I want to share that came out from our research is that the role of the national public audit institutions, those are in-house, because a lot of the trust in the system is not there for these conflict countries, because donors often do not trust the numbers come out from the local organizations, and that distrust feeds across the project design to project deliverables. And the one way to break through this is to actually get involved with those accountants or auditors who are left behind in the economy, to actually be trained in the methods of evaluation and monitoring that the donors or the funders are looking for, and actually let them speak the current situation in the local terms. So those are the three critical variables that came out from our research, and we call these critical variables as untapped assets. The asset, as a definition would suggest in economics, is that something that offered value, one would exchange for another valuable item, and in exchange, someone will have control to improve the asset. When we did our research with Yemen, and it was funded, and it was a partnership between the EAT and Rockefeller Foundation to demonstrate a rapid evaluation methodology called Cambridge Policy Bootcamp, to bring together relevant stakeholders to identify untapped assets, so the cost of intervention is actually reduced by leveraging the assets that the countries have, and also to identify the negative unintended consequences that the dwellers, i.e. people who live with these kind of challenges, actually can identify on the onset of developing a project or a program. And Karima was our critical co-creator in this project, because it was an action research directly done with the MOPIC, with the Yemeni government and her agency. And to her own surprise, Yemen actually had so many untapped assets that they can unleash to actually reduce the cost of burden on the donor and the financial institution, while making a campaign that those money that they're currently putting forward for a year or 6 months or in a very money piloted way could actually run much longer term. The second thing we also identify, when unintended consequences were outlined by the representatives of the country going through the methodology in an action research, that many of the unintended consequences are quite well known. So you can actually de-risk the investors by introducing some of those mitigating approaches, so that the investors or the donors also find satisfying that, yes, my money, the value for money is actually coming back. So those are the two critical points that I want to leave you with, is that instead of having a lot of broad scale statistical number just to create the alertness, we need to really get down into our knees and actually look into the solutions that are readily available by the people because they know the problem way more than I would ever know. And much of those is about putting that back into the lens of economics and finance, not to make it a market solution, but to make it a state-owned, market-driven, and participatory social solutions. In other words, every three of these entities needs to be part of the design process to deliver it to decomposition of the evidence process. And this is a process that we actually demonstrated to Yemen very successfully. And I believe Karima is here and she's actually trying to fundraise for some of the action.
Let's leave her some time.
Yeah.
Thank you.
Thank you so much.
Thank you for your contribution. And I think we'll continue with Yemen. So tell us more about the multi-sectoral work and the different levels of intervention based on the food system pathways.
شكرا جزيلا. سأتحدث باللغة العربية يعني. شكرا جزيلا. سأتحدث باللغة العربية. في الحقيقة أنا لن أعيد ذكر المؤشرات عن سوء التغذية في اليمن كما ذكرتها الدكتورة لارا، لكن فعليا ما يقارب المنتصف أطفال اليمن يعانون من التقزم و 16% منهم من الهزال، 2% فقط لديهم وزن زائد. وهذه المؤشرات في الحقيقة لم تتغير لفترات طويلة، منذ 10 سنوات لم تتغير هذه المؤشرات. ونظرا للمؤشرات المنذرة بالخطر انضمت اليمن لحركة السن أو Scaling Up Nutrition، توسيع نطاق التغذية، وهي حركة عالمية انضمت اليمن لها في العام 2012. هذا كان إحساس بالمسؤولية تجاه هذه المؤشرات التي تحتاج لاتخاذ إجراءات عاجلة من الحكومة اليمنية. كان انضمام اليمن جزء من القمة الأولى للنيوتريشن فور جروث سميت أو قمة التنمية من أجل النمو في العام 2012، وضمن التزامات إعداد الخطة القطاعية للتغذية. وبالتالي تم إنشاء سكرتارية رفع مستوى التغذية، وهي سكرتارية تنسيقية في وزارة التخطيط والتعاون الدولي. تم إنشاء لجنة تسيير قطاعية من حوالي 20 جهة من الجهات الحكومية ذات التأثير الأعلى على التغذية، منها أيضا مثلا وزارة الإعلام كجهة معنية بتغيير السلوك، المالية فيما يتعلق بالتمويل، وزارات مثل الزراعة والثروة السمكية والحماية الاجتماعية والصحة على رأسها بلا شك. ومن ثم تم إعداد الخطة القطاعية من خلال تشكيل فريق فني من كافة القطاعات، وتستهدف الخطة القطاعية الحماية الاجتماعية والنظام الصحي ونظم الغذاء، أيضا الثروة السمكية وتدخلاتها، باعتبار أن اليمن بلد متنوع جغرافيا، فلدينا مناطق ساحلية ومناطق جبلية ومناطق صحراوية، وبالتالي يجب أن تكون التدخلات تغطي كل هذه الاحتياجات المتنوعة، وهي بلا شك هي نقطة قوة وليست نقطة ضعف. فالسكرتارية هي نافذة للحكومة اليمنية على كل ما يحدث في العالم فيما يتعلق بالغذاء والتغذية. فكنا وما نزال المنصة التي تسهم في جمع كافة القطاعات حول طاولة واحدة، طاولة مستديرة، نحاول من خلال السكرتارية بناء الثقة بين كافة الأطراف والعمل سويا على التوافق حول خطط وآليات عمل مشتركة. خلال العام الماضي كان هناك القمة العالم Nutrition for Growth Summit أيضا، أو قمة التغذية من أجل النمو، وشاركت اليمن بعدة مستويات، ومنها من ضمن الياب Yemen Action Plan on Wasting، أو خطة اليمن لمجابهة هزال الأطفال. وكانت الخطة هي متعددة القطاعات كما تعلم، أيضا النظام الغذائي والصحي والحماية الاجتماعية وغيرها. أيضا كنا جزء من الفود سيستم دايلوجز أو حوارات النظم الغذائية، وعدينا مسارات النظم الغذائية، والمسارات تستهدف تغطية الاحتياجات الاجتماعية والجغرافية. فمثلا احتياجات المجتمع الساحلي ركزنا على المرأة، سواء كانت المرأة الريفية أو المرأة الساحلية. مثلا العلاقة بين ربط الفاقد والهدر من الغذاء بالصناعات الغذائية المنزلية. ربطنا أيضا بتغيير السلوك وتغذية اليافعات. الحماية الاجتماعية كانت حاضرة في هذه المسارات من خلال التغذية في المدارس والخبز المدعوم والصناعات الغذائية المنزلية. كان لدينا أيضا تدخلات كبيرة فيما يتعلق بالاقتصاد المنزلي، بالتوعية الصحية من خلال تغيير أو perspective of value. نعم أكيد. آخر شيء بختم فيه أنه أيضا القوانين والتشريعات والنظم واللوائح لها دور كبير في هذا المجال، لكن سيظل هذا التنظير إذا ظلت هذه الخطط على الطاولة وفي الوزارات، فبالتالي هي دعوة أيضا لتنفيذ هذه الخطط التي كلنا اشتغلنا عليها، وإن شاء الله يكون الأثر مستقبلا. شكرا جزيلا.
Thank you so much, Karima, and apologies for shortening your time. This is the beginning of the conversation. I thank everyone for joining us, and I think we already have to move to the closing session. Thank you so much, and I hope you join the conversation for later on.
تتفضلوا على القاعة الرئيسية، لأنه معالي الوزير رئيس المنتدى العربي للتنمية المستدامة لعام 2023 سيختتم أعمال هذا المنتدى. تفضلوا.